spot.
All right. Okay, well, thanks for having me. So assalamu alaikum to anybody who is checked in. I know we started a little bit late, so if you can't obviously tune in now, it'll still be available on YouTube and on Facebook. So thanks so much to Brother Akil for kind of sorting this all out technologically, and Rashid for allowing me to have a little bit of a talk here today. I'll start off just introducing myself. So my name is Alia, and I am an adult respirology fellow at the University of Alberta. Long story short, for people who don't know what that means, in a year time, inshallah, I'll be an adult respirologist and currently an internist. And I'll be presenting today a little talk about goals of care and end-of-life discussions. And if you don't know what that is, definitely reason to tune in, and hopefully we can learn more about that today. So we'll go to the second slide. Ultimately, I don't want this to be a significantly didactic, long lecture. I want it to be more of a discussion. My plan is to hopefully just speak for top 30 minutes and then just open things up for any questions, if there are any. I pretty much have had this topic high on my mind for over a year now, just through my experience working in the medical field, and with the current COVID situation, all the terminology that's being used, I thought it would be a perfect time to introduce it to the community at large. Main objectives today would be to talk about the Islamic perspective. So why is it important to talk about end of life and hold these discussions and talk about goals of care? I also wanted to talk a little bit about just medical terminology, specifically about what resuscitation means, what's a ventilator, intubation, what does it mean to go through what goals of care are and code status as well. And then I wanted to close it off with just a little bit of a stepwise practical approach, something that you can take to your parents, your loved ones, your family members, as something that you could do as far as documentation, go through what the regional protocol is here in Alberta, as it pertains to getting everything sorted for that purpose. So hopefully more of a practical steps at the end. So next slide. I wanted to start off by kind of joining it. We're at like a Muslim scenario here, talk about what this represents and the importance in Islam. And so something that's very beautiful, I think, about our religion is that it very nicely emphasizes the importance of life, but also of death, knowing that they are both very much intertwined. You can't have one without the other. There are many beautiful ayahs in the Quran where this is one of them in Surah Luqman, where ultimately you can read it and it says, "Indeed, Allah has knowledge of the hour and sends down the rain and knows what is in the wombs. And no soul perceives what it will earn tomorrow, and no soul perceives in what land it will die. Indeed, Allah is knowing and acquainted with all of you." Ultimately, we have this belief that we accept that death is coming, that it can be sudden, that it can be expected, that it doesn't discriminate based on, your age, your gender, what's going on in your life. And then it joins that concept with the concept of being prepared. And so you can extract this not only from the Quran, but from the Seerah of the Prophet ﷺ, where there's a lot of talk about getting your worldly issues and affairs in order, whether that includes paying off your debts, your loans, taking care of your personal relationships, and that's very much emphasized. And so this is really the importance in Islam. And then if we go to the next slide, and we can kind of merge that with like a practical in-hospital approach as to why it's so important, I wanted to emphasize this through describing 3 possible scenarios. And so, for one, imagine you have an 18-year-old who is young, previously healthy, no medical conditions, and just has or gets into a cycling accident. He ultimately falls down a hill, fractures a limb, or fractures his femur, which is just a bone in his lower extremity, and he requires urgent surgery, needs to be admitted. A second scenario could be, again, a young female who's 30, however, has a more complicated history, including underlying breast cancer that has spread to her brain and to her bones, and so rendering it essentially incurable. and is currently receiving chemotherapy, and let's say she suffers a complication or side effect wherein she, is significantly dry, requires, again, an admission to hospital to treat certain lab work electrolyte abnormalities. And then let's join that again with a third possible scenario where it's more of an older patient, an older gentleman presenting to the hospital. This patient is kind of more what we see in internal medicine, where they have a laundry list of comorbidities. Well, comorbidities just mean past medical conditions, as well as a long list of current medications. So let's say this patient has diabetes in addition to end-stage renal disease, being currently dialysis dependent, and let's say he's coming into the hospital with gangrene of a limb, again requiring admission to hospital. And let's also say this patient's actually quite confused or delirious at the same time, but they ultimately also need admission. So what do these three scenarios have in common, you might ask? Well, I would need to have a goals of care discussion with each of these patients, regardless of the differences in their medical profile or their history. So this is something that applies to anybody who requires an admission to hospital regardless of the reason. And some barriers that can exist is, my role is to have an open discussion with the patient and their family, to approach it empathetically and compassionately, to take into consideration their values, their goals, but also their medical profile, the likelihood that treatment will be successful, and also like their medications and all of that, and come into kind of a decision that is logical. But also, the patients themselves have to kind of have that understanding early on. I think it's very important to do that. Why, you may ask? Well, for one, imagine being in a hospital, you're in pain, you're afraid, there's a lot of unknown that's associated, and there's someone you've never met before in this setting who's talking to you about end of life and asking you to make really tough decisions. And on top of that, just bringing in the pandemic briefly, currently you can't allow family members into the emergency setting or the hospital setting unless, except in very extenuating circumstances. And so really the patient's there by themselves. And then add on that the possibility that the patient, being acutely ill, might not have the cognitive function in that moment of time to make these decisions. And so kind of joining all these factors together, really, it's quite important that you have these discussions with your family members and think about them ahead of time. So hopefully I've convinced you that goals of care discussions are of the utmost importance. And let's go on to talk a little bit about the terminology that is important to kind of make these decisions. So let's just arm ourselves with knowledge. And so we could start with the next slide. So that's the one that's about full code. So let's talk about these terms and what they mean. So full code, you probably heard of CPR before, cardiopulmonary resuscitation. Resuscitation ultimately means that you are reviving someone from unconsciousness or apparent death. So ultimately, someone you think has already died or passed away, and then you are doing resuscitation as a means to bring them back, for lack of a better word. Things that can approach this, so cardiac arrest, so that means that there is no pulse. Ultimately, the patient has lost consciousness, are unable to speak, that type of thing. And then respiratory arrest, they're unable to breathe on their own independently or oxygenate their vital organs appropriately. So if you have this scenario, then what do you do? So what does resuscitation look like? We can go to the next slide. And so ultimately resuscitation is something that can happen not only in a hospital setting, but anywhere. So if you or anyone that you know has had ACLS training before, they ultimately teach you how a code works, how resuscitation works. But in the hospital setting, if you're an outsider looking in, it definitely appears to be quite chaotic. You ultimately have an array of healthcare professionals that are present and ultimately trying to revive this patient. It includes the administration of multiple invasive lines, procedures, investigations, and then obviously chest compressions as part of that, and then possibly intubation, which we'll touch on later. Ultimately, unless you're in the healthcare field, you've probably only experienced this through TV shows, which are not as significantly accurate. So I do have a little short YouTube video that we could play, just to give you guys a little bit more information. We could probably start like 1 minute into the video if it's too long. And the slides can be available later if you'd like to kind of watch them in your own time as well. So we'll play that shortly. Sorry? Sure, it's playing? Yeah.
I can't start it for 1 minute inside.
That's okay.
So the guys have confessions. The tube is not going to be inserted into the
Okay.
You could...
Sorry, I'm just not watching it concurrently, but that's okay.
Now the bag is being squeezed. They can hear you. Everyone can hear you. So
Okay.
that's all what's happening.
Well, I can't see the video right now. That's okay. We'll talk a little bit about it more in depth, but sorry, I could have played it concurrently maybe. It's okay. You could just let it play. Let me know when it's done.
ETT with compressions. I think it's cycled.
It's done? Okay. That's just a little bit of a snippet. Sorry if there was no audio, but again, the link will be available if you're interested in looking over it in your own time. So we can move on to the next slide. So ultimately, when we do this resuscitative process, so you're doing the chest compressions, as you can see, you're trying to ventilate or you're trying to allow the patient to oxygenate through invasive measures. And the whole point is to try and buy some time. So when a person arrests or, they can't, there's no pulse or their lungs aren't working, they're at significant danger that their vital organs, specifically their brain, is not going to receive any oxygen. So ultimately, time is brain. And this has a risk of causing irreversible brain injury. And that's really what we try and prevent, primarily through undergoing CPR in this resuscitative process. Because if you don't do it, you risk, the patient being unable to regain any type of cognition, any ability to possibly take care of themselves, so to bathe, to undergo financial independence, even physical independence. All that is at risk the longer that they're arresting, or also even with CPR. So say you started on time, the longer that it goes on, the risk is significantly increases as well. And so you can go on to the next slide. So say you're doing the CPR, you're doing everything right. Even with that, the mortality or survival outcomes are very poor. And I don't think many people fully understand this, is that even in a healthy patient, sometimes the outcomes are quite poor. Obviously, age and other medical conditions can increase that risk, but it certainly exists. And so in patients where, so say your heart stopped beating and then through CPR you're able to, it starts up again, or what we call a return of spontaneous circulation, that will only happen in 30 to 40% of cases. And even patients that after that will, be transferred to the intensive care unit and receive other interventions or treatments, only 5 to 10% will actually survive to hospital discharge or make it out of the hospital. And even in cases where that does happen, oftentimes they are significantly debilitated, ultimately might need to go to long-term care facilities, seek out a lot of help with just basic activities of daily living because they can't do that on their own. And unfortunately, that is the vast majority of cases. But say, prior to that discharge component, you're in the intensive care, there are a lot of complications that can happen just by means of you being basically immobile in a medically induced coma. Those could include muscle atrophy or breakdown. They could include the development of ulcers in your stomach. They could include the development of blood clots as well, just to name a few. So it's not a pretty process. And we go on to the next slide. So what really happens while you're in the ICU, or what do they mean by mechanical life support? So you're supporting the heart function. We talked about that component. So that is the CPR, the chest compressions, maintaining the blood flow through the body to the vital organs. But then there's also mechanical life support that encompasses supporting your lungs. So your lungs can't breathe on their own, and so we need to support them. So how do we do that? Through a process called intubation. So there's a long tube that is usually introduced through the mouth. Sometimes an incision is made in the neck into the windpipe, and that in itself can also facilitate this oxygenation. But anyways, that tube is inserted and it's connected to what we call a ventilator. You've probably heard that term a lot, and ultimately it introduces air into the lungs and then out and allows them to oxygenate such that your vital organs are receiving the oxygen that they need. Other forms of mechanical life support include medications, so really strong medications. They're medications that we usually can't administer through peripheral IV, but rather we have to put in intravenous lines centrally. What that means is they're lines that are in your neck, in the groin area, sometimes directly into the bone, and they themselves have a lot of side effects. There's also other methods of life support or mechanisms of that. Sometimes you will require like the CVICU to be involved and to do other invasive measures, but these are ultimately what they're talking about. And let's just be clear here, these are usually methods, like mechanical life support is kind of a way to buy time until the underlying illness is hopefully treated, if possible, or reversed, bearing in mind that oftentimes that's unfortunately not possible. So go on to the next slide. Step down from that type of mechanical support is also non-invasive respiratory support that can be offered, usually through things like, I don't know if anyone's ever seen something like this, but through like a mask, a facial mask. So instead of the tube that goes deep into the lungs, this one's more superficial. You're still connected to a machine, and it can offer very high pressures and concentrations of oxygen to, again, just allow that oxygenation process to take place. As mentioned, this is a step down from intubation. However, you need to keep in mind that this is not something that is usually encouraged for all patients, and it's not appropriate for all medical conditions. So for example, since we have kind of COVID high on our minds as far as a respirologic illness or infection, this is not something that is being recommended unless there are other indications for its initiation, and that just has to do with the fact that the mortality or survival associated is significantly low. Sorry, the mortality is high, the survival is low, is lower than with intubation, for example. But what's really interesting is even with intubation, just to kind of give you guys some numbers from the literature, patients who are intubated, around 33% will survive. So quite low numbers. And the mortality in patients with COVID, for example, who require this intubation process can be as high as 60%. Things that increase that risk is your age. So if you're over 64 years of age, or if you have other medical conditions. But it does carry a high mortality. All right, you can go to the next slide. So what will end of life really look like in the intensive care unit? Like I said, the mortality is quite high, and so usually in scenarios where patients in the ICU or make it to the ICU, you will have signs or evidence of organ failure, and you'll basically experience a lot of family meetings. So the intensivist will hold them with the patient's family if the patient themselves are not able to speak. And so they speak on their behalf, more or less. And you make really tough decisions based on those conversations. So many family meetings, you review the goals of care. So again, keyword, citing why this is so important. And they usually involve like a multidisciplinary team, which basically means it's not just the physician, but you get input from social work, nursing staff, and other physicians who are possibly involved in the care, like not just the intensivist. Okay, so we could go on to the next slide. So that was all pretty much talking about resuscitation and that component of medical care. Sorry? Oh yeah, for sure. I'm talking a lot, so please add in questions in the comments if you have any as I go along, and I think Akil will kind of cite them as we go, and hopefully we can answer them. For you. And if translation is necessary, I do also speak Arabic, and so if that's something people are interested in, we could also do that as well. Okay, so we're on the terminology slide again. So that's all about resuscitation, but that's not the only option, and it's not always the best option for every patient. And so something else, if you guys have ever heard of do not resuscitate or a DNR order, I like to use allowing natural death. Instead, other terms you could use is withholding life support, which of note is something that's different from withdrawing life support. But ultimately, this is the result of a very fluid conversation with the patient, with their family members. It takes into consideration patient preference. In keeping, with their values, with their fears, their concerns, their wishes, sometimes their religious ideation. And we kind of join that with the medical and educated opinion that we can offer through experience. But this is an option. And then there's another term called palliation. This usually holds a negative connotation, correct me if I'm wrong, but oftentimes people relate palliation with comfort care, but they are sometimes different. They can work together, but they are sometimes different. Palliation ultimately relates to pain and symptom management. And it's something that any patient can and should benefit from. So they're having symptoms that are causing significant distress, whether that's shortness of breath, chest pain, whatever it may be. Palliation allows the introduction of treatments and other interventions that can help in that area. It can happen concurrently with medical management, so they're not exclusive, mutually exclusive. Comfort measures is something that can be introduced maybe a little bit later on in an illness that is irreversible, it's incurable. And really when patients are in the active stages of actually dying or passing away. And they do include the same types of, some similar medications or approaches as palliation, but escalated a little bit. Because obviously comfort is very important in that stage. All right, so those are some terms, and we can go on to the next slide. So if there are any terms I didn't touch on, again, please feel free to just comment below and we can talk about other things, but that's just the general overview of important terms that you should know and kind of understand, hopefully. Granted, it's difficult to comprehend what this actually looks like in real life and what it means for you as an individual, but this would be the first step. So now let's talk a little bit about what that looks like in Alberta. So if you recall the scenarios I mentioned before with the patients coming into hospital, we have this discussion with everybody. It's kind of a requirement to an admission where you have to have the goals of care form completed in a green sleeve and available so that all nursing staff, healthcare professionals are aware on first glance of the patient chart what their wishes would be in case of emergency. So if their heart stops beating or anything urgently happens while in hospital, we know that we aren't intervening in a way that is not in keeping with patient wishes and values. So what is your role, I guess, or what are some things that you could do right now? I mean, hopefully nobody ever is put in a position where they have to experience this with their loved ones or for themselves personally. But again, going back to our belief system, we all know that this is inevitable for everyone involved, and that preparation is kind of a part of that belief system. And so you start off by having, I think, honest discussions. I think that's important with yourself, but then also with your family members, with your loved ones, about what your wishes would be in an emergency, what your values would be in that case, about your medical conditions. You should know kind of what options are available. You know, seek that education or that knowledge through the AHS or Alberta Health Services website, which I will cite in a couple slides coming forward, and assign an agent or emergency contact. Kind of like with the third scenario where the patient was confused and could not speak for themselves. Assigning that emergency contact or agent will be very important because they will speak basically on your behalf should something happen. There is a hierarchy to the medical decision-making process. Obviously, first on the list is yourself. You make those decisions for yourself, but as mentioned, in certain circumstances, that's not possible, and so you can assign a substitute decision maker, which you will be asked about on admission. I guess Islamically, the term would be like a wali, for example, but that could be a family member. It could be a legally appointed person through a power of attorney, which is more of a legal process that you can undertake. But this would be something that, that you could think about. We could go on to the next slide. So the next step, I think, would be to learn about the regional Alberta process. So I alluded a little bit to the goals of care documentation and the green sleeve. So this is, I just kind of added in a PDF screenshot of the first and main page. So as you can see on the top, there are designations. And so for us as healthcare professionals, we'll kind of check the box following that discussion that I mentioned with the patient. So you can either be, you could divide it into three categories. There's R1, R2, R3. There's M1, M2, and then there's C1, C2. Sorry, this screenshot cut it off a little bit. But the three main categories going from top to bottom, where the top is full resuscitation. You know, give or take things like CPR, intubation. R3 would be where you would be open to receiving medications that can only be given in the intensive care unit, but that you don't want CPR and you don't want intubation. And then you go on to the second category, which is the M, and that's more so medical care. So these are people who, you know, you don't want any resuscitation. You don't want any of that CPR, intubation, you don't want to go to the ICU, but you want all medical management allowed to help treat your condition, to put it lightly. And then the C, goals of care, that category is more so like actively dying patients who you're ultimately stopping all interventions that are futile and that are prolonging. Like they basically aren't doing much of anything, and you're initiating kind of the stronger palliative approaches. And so we fill out this form. The most responsible physician will sign it and date it. I should mention that this is a fluid process, and so if you think about it more and you change your mind, this is something that can always, you can always change and evolves with the evolution of the patient's medical history. I have a link available in the slide. You can actually print this form out. There's a second page that I included on the second slide, so we could go on to the next slide. Just kind of the back component of this form, and it talks about the three kind of main categories that I talked about in a little bit more detail. But really, it's a lot to kind of go through on your own. I think that's why it's important to just hear it at least once. In the community, talk to your physician, your family doctor, whoever that may be, about them so that they can explain them to you as well. so that you're kind of forming the most educated decision or educated opinion about what is best for you. So ultimately, you can print it out and you can hold on to it. You know, some patients will hold on to it like on their fridge so that it's easily accessible should an ambulance need to come to their house or something like that, or should they need to be admitted, or, you know, at the very least, they're familiar with the terminology and are able to kind of hold these conversations and advocate for what their needs and values are. Go on to the next slide. So in addition to doing filling out the goals of care form and having those discussions, there's also a personal directive that you can fill out, and that's the link where you can access it. It's ultimately a legal document that you can fill out and make for the future. It basically assigns someone to make those decisions. So it goes under the pretense that you've had these discussions with this person and that they have a very strong understanding of what you would want if you were able to speak for yourself. Of note, it's an optional voluntary process if you do decide to do it, and it does not include financial matters. So that's more so what an enduring power of attorney or like a will would do, and other like legal documentation, stuff like that. And then obviously other things you can think about is burial and funeral arrangements and that type of thing. But I think, you know, these are probably the main categories as far as things that you can actually start thinking about now, because this is what it looks like in Alberta. And yeah, the next slide. I know this is a very like heavy topic, but you know, life is still beautiful, and there's a lot to learn and to gain and to enjoy. But I think the whole point is that thinking about these hard issues, hard topics, does not preclude from enjoying life. Because, as mentioned, I think that's a strong part of our belief system at the core. Is accepting both and kind of preparing for both. So I've talked a lot, so I don't know if there's any questions, Akil, that anyone's typed out or. Sorry?
It's just supposed to be a sunset?
Yeah, it's just supposed to be a sunset. Does that not indicate life? It indicates life for me, maybe not significantly. Yeah, that's just from a recent trip. We probably won't be able to go on any trips coming up for quite a while, but yeah.
Many people just say Assalamu alaikum.
Assalamu alaikum. Alaikum assalam.
Yeah. There's 3 people that have questions on Facebook. So
Oh, that's good.
If they want to drop any questions, even not related to your topic.
Yeah, for sure.
You have to repeat. They can't hear me.
Oh, they can't hear you. Okay, sorry. Akil's just talking. So there aren't any major questions related, but if you guys have any questions even not related to the topic, I guess medical questions or whatever it may be, we would be open to that as well.
You have questions?
So yeah, I mean, if you have any medical questions, because I am a doctor at the U of A, and so again in respirology, so if you have any questions in that area, feel free.
Okay, here's a general question.
Okay.
So I moderate all these comments on all like our social media. We get a lot of repeat questions. One of the things that annoys me the most is the spread of misinformation, right? So people would be like, oh, drinking warm tea alone and you don't need medicine, that cures you, right? So how do you go about dispelling misinformation?
Can they hear your question? That you said. I can repeat it.
Yeah, repeat it.
Okay.
Like myself.
Yeah, no worries. Okay, so Akil just asked a question about dispelling myths in medicine and kind of how we sort through that, because a lot of people will sometimes talk about, I think you brought up drinking milk as as a curative measure, or eating garlic or onions or whatever it may be. What can I say about that? I can't think of Islamically right off the top of my head, but it's kind of our what's the word I'm looking for? It's basically something that we have to do. It's our obligation. That's the word I'm looking for. It's our obligation, I think, as Muslims to always seek knowledge. This happens personally in my own household where something will show up on Facebook or will be propagated incorrectly. And it's easy sometimes to just click share and to be overwhelmed by that. But again, it's our obligation to look at the facts and what they are and to seek the people of knowledge who put in many years into kind of their education and seeking that out. And unless you're doing that, really you're doing yourself and people around you a disservice. So I think that's like the biggest thing I can say. It's an obligation, like it's borderline haram, I think, to kind of propagate stuff like that, because really some people might believe it and might choose that instead of seeking actual medical care. And if that happens, then you might be responsible for someone having a very negative outcome, or delaying their presentation to medical care, to a hospital, which can be quite dangerous. So although there is possibly some benefit from natural means and all of that, it's very, very important to, again, just make sure it's factual, and to understand that seeking that out does not mean that you do not or should not concurrently seek out medical care. Hope that answers your question.
That did answer.
Milk is good. I mean, it has other benefits, but probably not curative for like actual medical ailments.
That did answer my question. Just 1 second. I'm balancing this audio.
I'm just checking on Facebook as well, but
I think they can hear me now as well as you. Okay.
Oh, they can hear you now? Okay.
Assalamu alaikum. My son is on anti-rejection meds, Salsept, and I'm worried about visiting this Eid. Should we avoid visiting for his safety?
Sorry, he's on Salsept and...
She's worried about visiting him. Should she avoid visiting for his safety?
How old is he? I'm assuming he's an adult.
Yeah, so this is Heather. She's asking the question for her son. I don't know. Let's not ask her personal information over.
Yeah, no, for sure. I'm just worried about
so
visiting.
give me, what if he's under 10, what if he's under 20, and what if he's under 40?
Okay, well, let's just say in general, I mean, so being on Salsept or certain medications like that basically means you're immunocompromised. So your immune system is not as strong as someone else equal in age and past medical history. So I'm sure you know this, and that's why you're asking the question, which is a very good question. If you are taking the right precautions, then there is no harm. But obviously, you always need to ask and kind of triage yourself. Like if you're having symptoms, so I'm sure you've heard this all over. If you're having like a fever or cough, if you're unwell, if you've been in contact with someone who's unwell, or I don't know if this question is specifically to the pandemic, but if you've been in contact with someone who has it, or if you yourself are under recommendation to self-isolate, or for reasons of travel or whatever it may be, then you should follow those guidelines and definitely isolate and avoid visiting in person. But it's kind of a case-by-case basis. I obviously don't know the full story, so I would recommend that you speak to like your doctor, or have your son or daughter, assuming they're an adult, speak to their physician, because they know their full medical history and their condition, and can better guide that. But let's say they're on a medication like that, but their lab work looks good, they're otherwise fairly healthy or whatever it may be, then it would be important to take other precautions. Like it might be kind of a stepwise approach. So it really just depends on the specific circumstance. Obviously, things that you should do regardless is wash your hands, you could wear a mask, wearing gloves if you're doing the gloves correctly, which is that you're not touching your face with your gloves on, or touching other surfaces with them on, because then it just propagates germs, and maintaining the safe distance and all of that. So just following the regular regional guidelines should be okay.
Inshallah.
But seek out your son's doctor, obviously.
May Allah make it easy for him.
Yeah, I mean.
So, another question for me again. A lot of our viewers, alhamdulillah, they're very into Islam and they have a strong faith, right? So they make dua, they pray, they do their best from a spiritual perspective, right? But we know, like in Islam, you just can't be spiritual. You also have to go out, seek the knowledge, and be active and whatnot, right? But some people are hesitant to take that extra step and think that just their belief alone, without action, is enough. So how do you get to encouraging people, especially people from like a strong cultural background, to go out and seek like Western knowledge of medicine and like be active in like Western like university clubs or going to university in order to improve their self?
It's a really good question. I don't know. I mean, I hope that's not an active thought process currently, because I feel like the whole Western, Eastern, like I think you're talking about like Western medicine versus naturopathic medicine, probably. Not necessarily. So you mean more so like just avoiding going to the hospital because you don't like it? Yeah. Well, I would first start off by thinking, like wondering about the reasons or digesting the reasons why they feel that way. So it's probably going to be a bit more complicated. So certain reasons that might push patients to avoid hospitals, previous negative experiences, possibly with themselves personally or family members, possibly just having like a negative connotation of a hospital and death maybe, or them themselves not having I guess complete comfort with the concept. It could also just be that you're not sure about what happens there or what the medical process is like. Those might be like top 3 reasons I could think of as far as why someone would not want to do that. And so in order to try and overcome that, I think you need to look at each of the reasons why. Again, they'll vary from person to person. So you'll really have to seek out the reasons behind that and try and treat them. Yeah. So learn about what goes on in the hospital. Talk to people who work in the hospital, people in the medical field. If there's something that you're fearful of or concerned about, just seek it out. And you mentioned something about this being stimulated from a belief system or a strong belief system. So I would argue that part of that, especially Islamically, is that you seek knowledge from the people of knowledge, right? The people who learn it and study it and whatever that may be, which in this case would be like their family physician or their specific physician or people who work in the hospital. And so that really is an obligation for yourself because your body is, at the end of the day, your health is an amana. And it's something that we should all take care of and treat. And so that includes seeking out knowledge, that includes taking those means and treating them if need be. I don't know if that answers your question. But I think it's definitely like a religious obligation. Yeah. But again, if there's the fears, if there's an underlying fear that's stimulating or encouraging that, then you just need to tease it out. You need to work through it.
Yeah. You can pan to me, Mary. Pan to me. So, guys get to see behind the scenes. Okay, so like in previous episodes, we also talked about like culture versus faith, or those. I think that was with Sheikh Sadiq, who is a psychologist. Culture versus faith. So you can check out that episode to see how to be mindful about things that go on, and like know that where your religion is also a thing of action. And I think you said that really goodly. But now I find like a lot of people, they try and be mindful and they have the best of intentions to seek out knowledge and they're actively doing it. But at the end of the day, they allow themselves to let anecdotes or like stories control them, control their emotions over like facts, right? Like, oh, my cousin's uncle friend had it and it was that way, so it's that way for everyone, right? Despite all the facts, despite all the research pointing to different results. What do you say to those people, and how can you like not let your emotions from anecdotes override your rationale?
Yeah, really good question. Very good point. I think, so I'm not a psychologist or anything like that, but I think the first step is to acknowledge that what is driving your decision, for example, to not seek out knowledge, to not seek out doctors, to believe whatever you see on Facebook or articles. So understand that you're doing that first off, so that you're consciously doing this. Because if you don't acknowledge behavior, like a behavior, then there's no way of fixing it, right? Or of, dealing with it. So first you acknowledge it, and then you look at the reasons why, and try and work through them. Hopefully, again, you can, I guess we're doing this at Rashid, so tie into your belief system as a Muslim and know that a lot of what stimulates what we do is seeking out knowledge, and that's what we're encouraged to do, even in the Sirah. Like, we're supposed to ask questions. Medically, we're supposed to be inquisitive and not just follow blindly. Like, that's the whole part. You're supposed to ask questions, whether it's religion, politics, medical knowledge is a part of that, and seek it out from the right sources. Like I said, that's your obligation. I understand that it might be difficult. Like currently, like there's a lot of clickbait and a lot of articles that show up and are propagated. Like I said, I've experienced that in my own household. And I think if you yourself are experiencing that with a family member or with a loved one, the best way is just to approach it lovingly first off, and to ask them, like, where does this come from? How are you yourself, what makes you so confident that this is true, and that this is better than what is considered general practice, whatever it may be. And you'll find this, oftentimes people can't support that, right? They can't, they don't have that literature, they don't have that evidence, they don't have that understanding, and they'll realize it on their own, I think, fairly easily. Like, you might be very much surprised. But the key is that you ask. The key is that you look into the sources. And when I say ask people who, again, have put in years into studying this topic, or who are people, again, of quote-unquote knowledge in the area. Yeah, I hope that answers your question.
That makes a lot of sense. And I think a good point that you just mentioned was having compassion, or approaching with like love and compassion. Because if you aggressively come up and I say, hey, Alia, I think you're wrong because this, right?
Yes.
Am I gonna be convincing to you? I don't think so. But if I say, hey, I'm really concerned about your health and well-being, have you actually looked into this? It like breaks down their defenses more, right?
Absolutely, absolutely. And honestly, isn't that like a beautiful concept in our religion anyways? Like, if any topic is, you need to approach people from a place of understanding and a place of equality, rather than I'm better, I'm correct, and you're wrong. And as soon as you do that, defenses are down and people are much more receptive to the information that you're providing. I mean, I deal with that every day with my own patients, where, I'm making recommendations, medical or whatever it may be, but, what the patient is bringing to the table is their own previous experiences, their fears of, taking this medication or whatever it may be. They might have other motives. It could be financial. They could not afford it. It might be fear-based, again, negative experiences like I mentioned. And so it's my job to approach things empathetically, make recommendations, and support them. Support them with the reasons why, and create an environment that makes the patient comfortable to share those fears and those values and those concerns. Because if they feel that they can do that in a safe environment, I can actually then dispel some of those myths, and I have that area, like the space to do that, and to ultimately increase the likelihood that they're going to follow the recommendation that I'm making, because they actually understand where it's coming from, as opposed to the black and white approach, I'm right, you're wrong, right, which isn't going to work with anybody.
Definitely, and I find that a lot too. Like when we're given for fiqh or fatwa, those series, we don't just say this is a ruling because X, Y, and Z. We talk about the foundations, the origins of where it comes, those two, right? How it was derived. And when people understand it's good for them, and this is like the basis, they don't see the surface level, but they get the depth from the message. It's more convincing, and they really get on board with your advice there.
Absolutely.
But this has got to be really harsh on you, right? Like if you're in these situations where I know people experience anxiety, but you see them experiencing anxiety a lot, or you see them having a lot of pressure or sadness on them. How do you, as an individual, stay positive, or how do you stay mindful and compassionate despite seeing so many sad cases?
Yeah, it's a really good question. So myself as like a
Yeah.
physician in the hospital.
Yeah, like you as Alia, how do you?
Yeah, I mean, honestly, not to sound corny, but a lot of it comes from a belief system.
Yeah.
You know, you understand at your core that there's life and there's death and there's suffering and there's happiness, and these are all normal things that humans are meant to experience. And it's your job kind of as far as what to extract from it. So for me, like when I go into work, I have an understanding that this is a part of life and that I'm in a position where despite all the hardships that you mentioned, there's also a lot of good and things that I take personally where I learned from my patients who are going through these really tough circumstances, making these really tough decisions. It really puts things into perspective for me, and again, just strengthens that core belief system.
Kind of sounds
And
like,
obviously you need to have things outside of medicine.
yeah, right.
Yeah, so obviously live your life and
Yeah.
have all of that, but
Like being alive or like experiencing life is a big part of death is like kind of like what you're saying, like what I'm getting at you're saying, right? Because like I don't know, I'd be I don't think I can handle like a position like that, to be honest. We have lots of other viewers. I'm just gonna remind you guys, if you have questions, please do ask them. We're gonna be, I'll give us like 5 more minutes, right?
yeah, sounds good.
But I'll also name drop. We're doing a series called Ash-Shama'il al-Muhammadiyya. Well, it's actually based off of a book. And in that we look at how the Prophet Muhammad sallallahu alaihi wasallam, peace and blessings be upon him, lived his life and how he interacted with compassion and kindness to other people, even in situations when you're dealing with something as tragic or sad as the passing of a loved one. Okay, you said you had your patients teach you a lot of lessons, right? So can you tell me a story about like what's like the greatest lesson you learned from a patient?
Oh wow, putting me on the spot.
Yeah.
That's difficult.
That is a difficult
Because
question.
there really are so many. I mean, I guess if I'm going to extract one right away, it would be like from a recent experience.
Yeah, that's fine.
Just with the current pandemic, as I mentioned, you know, hospitals with their policies are just not allowing as many visitors or people to come in and see their patient, except unless they're dying, obviously, and there's certain criteria to be met. So there was one patient who presented from out of town. And so I work in the lung department, so respirology, and so she was coming in with respirologic failure, basically. She needed that BiPAP machine, which is part of the non-invasive ventilation, but she was also confused because of her underlying condition, so COPD, and long story short, but ultimately her cognition was impaired as a result, and so she was not tolerating the mask and not tolerating that intervention, which happens sometimes. Yeah. And in which cases you usually need to go, kind of going back to my topic, you have to go to the agent or to the primary contact person or decision maker, which in this case was her husband. But again, they're not allowed in the hospital.
Yeah, so there's lots of barriers there.
So we kind of had to work together with like the charge nurse and everybody involved to just make a circumstance where he was able to talk to her and to interact with her. And like subhanAllah, that was enough for her to kind of understand maybe a little bit more where she was, and he was able to advocate for her wishes, which was ultimately that she didn't want this mask. She didn't want this treatment if it ever came to that. Medical management beyond that, and we were able to kind of do that for her and for the family. And so I don't know, maybe I'm bringing it or tying it in more to the talk that I gave, but it just goes to show you how important it is to have these conversations. Yeah. Because you never know. It could happen today, tomorrow, and you know, who are the people who are going to advocate for you or to speak to what your wishes are?
Yeah.
You got to think about that stuff.
Every soul shall taste death and return to Allah subhanahu wa ta'ala.
Exactly, words of wisdom.
That's not
It's
my
true,
words,
and honestly, this
but
is the
yeah.
whole point of this talk, is really because unless you're in the hospital and you're seeing this every day, it's not going to be at the forefront of your mind. But then life happens, and we believe that it could happen anytime, and so you're put in those circumstances, which again, I wouldn't wish on anyone. Inshallah, they're delayed for everybody, but it could very well happen. And then the question is, what is that process going to look like, and for you or for your loved ones, and what are the decisions you'll have to make? No one knows until they're there, but definitely it's important to think about it and to just gain knowledge again in that area because it will help.
I see.
Yeah.
I have a lot more questions, but looking at the group chat, not the group chat, what is this thing called? The
Facebook.
live stream chat or whatever. We have
Yeah.
a question from Sister Aisha. She's asking, what is your say on MAID made on Muslim patients?
Oh, wow. Sister Aisha went straight for straight for a really easy topic. So I can't really comment on that. I'm not a bioethicist or like in the bioethics of Islam or anything like that. So I'm probably not the best person to answer it. What I can say is I can shed some light on my role personally, like as a Muslim healthcare professional.
Yeah.
So even as a professional that's not Muslim, whatever it may be, if you yourself have opinions or feelings about that process, whatever it may be, what's nice about our system is you can refer them to someone else who might be able to help them. So a colleague of yours, another healthcare professional, whatever it may be, so that they can kind of help address that concern if you're not comfortable yourself. So that's an option. But kind of taking a few steps back, when a patient approaches me with that, my first inclination is to understand where they're coming from. Oftentimes, patients will come in with those requests because they're in pain and because they're suffering, and it's just multifaceted, psychological, physical. And the reason they're maybe bringing this up in some cases is because they think that's the only way to possibly treat it or whatever it may be. And so my role in that circumstance would be like, yes, that is an option. I could refer you to someone who can speak to you more about it. However, let's deal with the other issues as well, whether it's psychological, depression, anxiety, fear, whether it's physical pain. I alluded initially about palliation, right, and pain and symptom control, and how it's not mutually exclusive to medical management. And so if those things haven't been started, I can start those things. There's a lot of medications that can start. There's a lot of interventions in the community that you could initiate to try and help patients sort through whatever it is that they're going through. So that would kind of be my approach. Islamically, I won't delve into that, but again, it's just if it's you and your comfort level as a healthcare professional, and it's definitely a possibility to kind of, again, as long as you're still helping the patient and directing them to where they need to go, it's something that you can do.
All right.
Hope that answers your question.
Yeah, thank you for that question. And thank you for all the other good questions. Keep them coming, please. I have my phone up and I'm checking them all. So me, what I do, aside from this whole virtual thing, is I work with a lot of youths, right? So we do youth programs, we take them out, we do camps, and I get to see a lot of youngsters. I see guys that are like from the age of 4 turn like 12, and then like 12-year-olds turn 16-year-olds. So like they're like in their youth, their prime, and they just like sometimes feel like they're immortal, you know what I mean? So
Yeah.
how do I like, but then, yeah, there's the unfortunate cases where I do see like some young guys in the community pass away, and we've had like a lot of janazas for people younger than me, right? Which is really sad. But every time there's a janaza for like a young individual, the masjid is always full. People always come out and go to the procession. How could we, how can I, or how would you advise me to advise the young guys to be mindful of their mortality, to not think they're going to live forever?
Really good question. I mean, how do you advise someone? Provide them with knowledge.
Yeah.
I think knowledge can come from two places.
Which are?
One, listening to people's stories, their experiences, seeking it out in books, seeking it out from people who have had those experiences. And then the second place is obviously through your own personal experiences. Life will teach you things as you go through it.
Yeah.
You will have, inevitably, unfortunately, you will have an acquaintance, a family member, a friend, yourself might go through these issues. I guess before you do, you'll ultimately will have that experience through someone else. Now, having that experience and actually stopping to ponder it and think about it and gain something that's applicable to your life from it, those are two different things. You have to make that conscious decision. You could have a friend or someone who goes through something like that, life-altering car accident, maybe they pass away, right? But unless you stop and think about it and gain something from it, with regards to your own mortality, you might not benefit anything, right?
That's
might
true.
just go straight over your head. But ultimately, that's definitely an area to gain experience. I think for yourself, because you're saying like, how would you share that with them? Possibly through stories, again, of things that you've experienced or stories from other people who have experienced them. Extract it from religion and through our faith as well. Like I mentioned, one of the surahs, and ultimately, like I said, that's at the basis of our core belief system, is that we're all going to die and that it doesn't discriminate based on your age, doesn't discriminate based on where you are in your life. And all you need to do is look around you, and the stories are, and the patient or the real life experiences are there. You just have to stop and have that ta'ammul and have that thought to think about those experiences and again, extract things that are applicable to your own life.
I see.
I don't know if that answers your question.
Yeah, that does make sense because a lot of these, like a lot of these stories are there, but if you don't search for them or if you're not mindful about them, they don't like become apparent, right?
Yeah, and everybody's journey is different. It's your personal journey, and yeah.
Thank you for coming out today.
Yeah,
there are
thanks for having me.
a lot of people I'm sure that benefited from this talk, right?
I really hope so, inshallah.
Yeah, it's not a topic we normally like touch on, but I'm so happy that we did it today. And like with Ramadan closing, I hope that we can continue this series after Ramadan. So subscribe, follow, and share all those thingies. But do you have any closing remarks or anything you'd like to say before we end off this episode?
No, I just wanted to thank you for having me. Again, I know it's a little bit of a sober topic possibly to talk about or to address, but my hope is, if anything, it just has you stop and think about it. Explain it to your parents, to your loved ones, have them think about it, because yeah, you just never know. It's something it's easier to think about this early on as opposed to right when you're sick or unwell or, God forbid, in the hospital and having to make these really big decisions. And so, yeah, I hope it helped. Thanks for having me. And
Jazakallah khair.
yeah, Jazakallah khair. Thank you.
Bye, everyone. Assalamu alaikum.